This Dr. Satish Reddy, emergency physician, Yashoda. So today's topic is chemical tissue injury. It will be presented by Dr. Dedipya, consultant emergency medicine in Sunshine Hospital, Gachibowli. So go ahead, Dr. Dedipya.
Yeah, sure. Thank you, sir. Good evening, everyone. I'm Dr. Dedipya. I'm ER consultant in Kim Sunshine Gachibowli Hospitals, Gachibowli. So it's a very good opportunity to get through this session. I would like to thank Dr. Raghu, sir, our HOD, Yashoda Hospitals, Malakpet, for giving me this opportunity. And also thank you, Satish, sir, for moderating the session. So is my screen visible for everyone? Can you guys see the screen?
Yeah.
Yeah. All right. So today's topic is a very fascinating and interesting topic, as this is one of the uh, most commonly, significantly seen toxicology cases, both in developing countries and developed countries. So the why the template is like the airway, breathing, circulation, and the burn you can't see. There's a reason why I chose this title, because corrosive poisoning, it's not merely a gastrointestinal injury. It is always an airway, breathing, circulation emergency. So let's start the session. So a typical scenario in your ER we would see is a 30-year-old gentleman who comes with history of ingestion of a toilet cleaner, acid, 6 hours ago, presented with oropharyngeal pain and both difficulty and painful swallowing, with no history of chest pain, epigastric pain, vomiting, or blood vomitus. So on examination, you can see there are oral and pharyngeal mucosal burns, but in systemic examination, there is nothing significant. This would be a typical scenario. So, so what are corrosives? So any substance that causes the chemical destruction of a tissue is considered as a corrosive. It's an umbrella term for both acids and alkalis. So alkalis are mostly called caustics usually, but corrosives include both acids and alkali. So coming to alkali, the pH is always more than 7. Very common household items like, drain cleaners, which has sodium hydroxide, batteries, which have potassium hydroxide, bleach, which has sodium hypochlorite. These are your commonly available alkali forms. Usually, alkalis cause a deeper injury compared to acids because of a pathophysiology called liquefaction necrosis. So we'll discuss what is liquefaction necrosis. So this hydroxide ion, so it reacts with the lipids, which forms a soapy-like structure, which is called saponification. It itself destroys the cell membrane. Also, the proteins get digested, not coagulated, unlike acid burns. So here the tissue becomes soft and swollen because of more water absorption. Here, since there is no coagulation, there is no formation of eschar, so there is no mechanical barrier which is causing deeper penetration. So as a result, you will find very progressively deep tissue destruction, which affects esophagus more than the stomach. So coming to acids, acids are always pH less than 7. Common household items like cleaning agents like hydrochloric acid, rust removers like hydrofluoric acid, batteries like sulfuric acid can cause coagulation necrosis, which are relatively superficial burns compared to alkali burns. So coagulation necrosis, what happens is there is protein denaturation. Structurally, the protein is broke down with enzyme inactivation. This in itself will cause an eschar formation. So the coagulated dead tissue, the proteins also precipitate. This forms a firm, opaque, cooked appearance compared to your alkali burns, which show a soft and swollen appearance. Since here the eschar is formed, it acts as a mechanical barrier, so it limits any deeper penetration of acid into further structures. So it is a superficial injury. It predominantly affects the stomach. So one exception to this usual acid rules is the hydrofluoric acid ingestion. This acid behaves like an alkali in severity and systemic toxicity. So it unique features are it causes very systemic severe toxicity with deep tissue injury. So what happens is there can be electrolyte imbalances like hypocalcemia, hypomagnesemia, hyperkalemia, which like in turn causes arrhythmias like prolonged QT intervals, VT. So hypocalcemia causing tetany and tetanic seizures. So most of the life-threatening complications are because of this acid. So treatment, we would treat it with IV calcium gluconate. So, coming to epidemiology, so this is one poisoning where it is consumed both equally in developing and developed countries. Developed countries more prone for alkali ingestion because of more household cleaning products or like and there is better regulation, hence the lower the mortality. In developing countries like India, there is more frequency of acid ingestion and there is higher severity and often used in mostly suicidal attempts. Coming to age, the mean age is 26 years, like 20 to 34 years of age, compared to, and more female predisposition is present and more in urban areas compared to the rural areas. And mode of availability is mostly through home. And more commonly consumed product is acid compared to the alkali. And often there is predisposing psychiatric illness for most of the patients. So how are the type of exposures like what is the mode of ingestions? First, very common thing is the intentional ingestion. So in adults or adolescents, mostly predisposed by a suicidal intent, which cause severe injuries. Then is your accidental ingestion, mostly in children or toddlers. A very smaller volume ingestion can be seen. Rarely you see occupational or industrial exposure with involvement of skin, eye, or inhalational issues. So through the course, we will discuss what is the role of gastric lavage or emesis, neutralization by any by acid or alkali, or NG tube placement, role of steroids, role of PPIs, endoscopy, and CT. So, based on this, the clinical decision, it's very important because intentional ingestions have the highest form of mortality and morbidity. So, and also depending upon the variability in the agent type, concentration of the corrosive intent. So, the management mostly should be individualized rather than a protocol based approach. So history is very important in this poisons. The very important five W's are five. Like the first one is who. So who took the substance? Like who is the child? Whether it's an adult, whether it's a pregnant woman, whether it's an adult. So while inquiring this, you get to know the risk and intent of the issue. So the second thing is what? So what type of substance? Whether it is an acid, whether it's an alkali, like whether it is household concentrated corrosive or is it an industrial level corrosive, or what form it is? Is it in a liquid form or is it in a solid form? So a liquid form tend to have the volatile capacity, so it goes deeper into the tissues, whereas the solid forms will cause more severe oropharyngeal burns. So that is very important to assess the severity and risk of the injury. Then coming to when. So time since ingestion is very important because there is a window period where cannot do endoscopy as the tissue is very fragile. So time since the ingestion is very important. So within 12 to 24 hours to 48 hours is where we do the endoscopy. And then next comes your where. Where is what are the circumstances that triggered the event, whether it is in a home or whether it is in a workplace, whether the container is it a labeled container or an unlabeled container. This is very important. Why is like to know the intent and for all the medico legal perspectives, and how much is how much is also very important because severity of the injury is based upon the whether it's a large volume ingestion or a small volume ingestion. And most commonly missed history point is what happened after the ingestion. So what were the events? What happened right after the ingestion? Did the person retch it out? Did they try to do emesis? Did they vomit? Or did they neutralize it with some soap and water or with some milk, water, something else? So oftentimes what happened after is sometimes hidden. So please try to find out what happened after as well. So now when the patient comes, always look for the airway, look for patency of the airway, like whether the person is drooling, whether he has oropharyngeal burns, whether he's having labored breathing. And the systemic features would come with dysphagia, odynophagia, vomitings, hematemesis. So in airway, always notice for stridor, any hoarseness of voice and any breathlessness. So classically, skin, some of the corrosives will present like this, like they give us a diagnostic clue called dribble burns. So there are the superficial burns present over the oral cavity, mouth, and neck and chest. Sometimes because whether when the person is trying to swallow, they might spit it. That forms spillage of the corrosive all over through the area. So this dribbling of the acid will cause the dribbling burns, and often it goes to the eye as well. The patient will present with severe pain, and even severe cases there is vision loss. So, how is the progression of the disease? So, the based on the time, we have the events. Like if it is less than 1 day, necrosis usually starts, and 24 to 72 hours, it starts with ulceration, inflammation. 3 to 7 days, it starts with granulation and fibrosis. Post 2 to 8 weeks, stricture formation is seen. So during the progression of disease, maximum tissue friability occurs between 5th to 14th day, which has high perforation risk, which at this time endoscopy should be avoided. So coming to labs, we do have a point of care ABG testing in our ERs. So lactates is a very good prognostic marker. The higher the lactates, the bad the prognosis. Why increase of lactates? Because at cellular level, hypoxia is happening and there is tissue necrosis, which causes lactates and metabolic acidosis. And raised inflammatory markers like C-reactive protein or WBC shows that there is some acute inflammation in the body. And in severe cases where there is peritonitis or extremely complicated cases, the patient can end up in DIC like state where the patient can have thrombocytopenia as well. So there is a derangement in the LFTs. If there is dehydration, please go through the hematocrit values, look for anemia, see for electrolyte imbalances as we already discussed, calcium, magnesium, sodium, potassium, and all the toxins can cause prerenal AKI. So is it a toxin related or something? You also have to evaluate. Coming to investigations, in a very stable patients who's having chest pain, upper abdominal pain, tenderness, epigastric pain, can safely go through a chest X-ray and an abdomen X-ray in an erect position. So the usual findings are just right below the diaphragm, you can see air accumulation. So it indicates some sort of perforation, esophageal perforation. Other than this, you can find pneumomediastinum. Sometimes the pneumomediastinum expands to the pleural cavity, causing pleural effusion and pneumothorax, toxic pneumothorax. And subcutaneous emphysema is present, pneumoperitoneum is present. In most of the complicated cases, it can end up as peritonitis, which shows as a dilated bowel loops with air fluid levels in the X-ray. So, coming to CT scan, recent studies say that CT scan has very good, positive results. Like CT scan is indicated in many cases. It actually detects the depth of the injury, if there is any necrosis or perforation. So, for taking surgical decisions, CT scan, they are choosing CT scan over endoscopy as a better decision maker. So we have grading system in CT scan as grade 1 to 3, as you can see in the picture. So grade 1 has a normal appearance. Grade 2 has, there is soft tissue edema over the wall of the esophagus. And in grade 3, it is a transmural, the whole thickness of the esophagus from mucosa to serosa. That is an absent wall enhancement. So should be endoscopy. Coming to endoscopy, it is considered gold standard. It should be done in all patients who are hemodynamically stable and have no signs of mediastinitis or peritonitis. Ideal timing is 12 to 24 hours, which is the best period. So we do have a classification called Jargar grading. So if it is a zero grade, it is a normal mucosa. If it is a grade 2, you have superficial ulcers involving mucosa where there is edema and erythema. Sometimes there is superficial localized ulcers with whitish membranes over the mucosa. And type 2B is your deep ulcers involving almost all the circumferential mucosa. And 3 is your necrotic state where there are focal areas of necrosis. And also this necrosis can involve the whole circumference. So basically, endoscopy grades the mucosal injury, but CT evaluates the transmural injury. So when to do endoscopy? So any suspected perforation or when there is when to avoid endoscopy is when you have any suspected perforation, laryngeal or epiglottic involvement is there. When there is third degree burn of hypopharynx, or you have to avoid in the days between 5 to 15 days as there is tissue softening with has increased risk of perforation. When to do a contrast-based CT? When it is having higher suspicion on mediastinitis or peritonitis, or when there is a high-grade injury documented already in an endoscopy, which says there is transmural necrosis in the patient. And also in the patient sometimes who cannot undergo an endoscopic examination. So for the assessment of GI tract injury beyond the stomach, you can go through a CECT abdomen. So management always is your airway is the first priority. So always consider a stridor is an airway emergency. So how do we intubate these patients? Like early intubation is very critical because there is high chances that the edema occurs in a corrosive poisoning. So always choose a gentle controlled intubation. Use railroad techniques where you can use bougie or fibro optic intubation or use a video laryngoscopy. So in case of difficult RSI or difficult intubation, please do an awake intubation so that you can not paralyze the patient and ventilation is not compromised. So in cannot intubate, cannot oxygenation conditions, you always have to go with front of neck access. Seek for an expert help. Uh, Regarding the fluid resuscitation, you can start with crystalloids, 20 ml per kg bolus. And coming back to the airway, so is there any role of steroids for laryngeal edema? So it's a very controversial thing. Usually, role of steroids is negative in corrosive poisoning, but when there is an airway edema, there is only least beneficial role. You can give a trial of steroid to temporarily reduce the edema in the airway. So then role of decontamination. So no role of charcoal. Why there is no role of charcoal or lavage in this case is charcoal usually binds to our organic toxins. So corrosive is not an this organic toxin. So it actually the corrosive what the patient consumes will directly immediately act within seconds and minutes. So there is no role of charcoal. Also, there is high chance of aspiration. And if you are planning a patient to undergo endoscopy, the visualization is altered if you give a charcoal lavage. Coming back to neutralization with milk, water, or like there is no specific antidote. It will only damage an exothermic reaction. You often see patients who say that right after the harpic ingestion, we just gave them the soap water or we just gave them some milk. So, but it only causes a secondary injury. So, what happens is when you are trying to neutralize it, you are causing an exothermic reaction. So, there is already a burn. So, you are causing a secondary burn injury to an already existing primary burn. So all these things should be avoided to reduce the perforation risk. So role of NG tube. So NG tube is ideally should not be placed in ER. Many studies say that. But through a guided procedure under vision in endoscopy, it can be done by an medical expert like a medical gastro. The advantage of NG tube is it still ensures the patency of the esophageal lumen, so that there can be a delayed presentation of a esophageal stricture. So, but the disadvantage is it often leads to a long stricture through the course of the tube. The stricture forms surrounding the tube now, and also it acts as a focus of infection now. And the reflexes, the gastroesophageal reflexes are worsened because of the NG tube, and it also is causing delay in the mucosal healing. So you can wait for the Ryle's tube. If an emergency endoscopy is done, can be placed through that. Role of PPIs. The pantoprazole has very important role in corrosive poisoning. You can start with 40 mg IV BD. You can double the dose. If it's still not reducing, you can start an pantoprazole infusion. It reduces secondary injury. So role of steroids are always controversial. There have been hundreds of journals and articles saying they're routinely not indicated. They're not showing any beneficial role either in pediatrics and in adults. Some trials say that it is only considered in grade 2 injuries. Um Role of antibiotics usually not recommended. Only indications are when there is infection and sepsis, patient is having necrosis or perforation in a CT scan, then you can start off with broad spectrum antibiotics if you are anticipating any peritonitis or sepsis. Coming back to analgesia, it is the most important thing that we have to do in a corrosive poisoning. First, we will discuss what not to give as an analgesics in corrosive poisoning. You shouldn't give NSAIDs like diclo or ibuprofen since it has higher tendency of bleeding. So that itself will cause a gastric injury. So what is the choice of drug is fentanyl and morphine. Fenta you can start with 1 to 2 mics per kg IV, and morphine also like 0.1 mg per kg IV. So you can always escalate to the infusions if the pain is not reducing. So regarding tramadol itself will cause retching and vomiting. So it can be avoided. So paracetamol can be given along with the fentanyl, along with the opioids. You can always give a trial of paracetamol. So coming to nutrition, which is very important in esophageal this emergency is grade 1 injuries, orally diet can be allowed if the patient given if he is able to swallow. So grade 2, we have to place an NG tube. So when there is no adequate oral feeding within days, either an endoscopic nasogastric tube or a nasojejunal tube has to be placed. If still not working, you have to place a feeding jejunostomy. So it should maintain an optimum nutrition. But in all grade 3 or grade 2A injuries, always prefer a total parenteral nutrition. So coming to endoscopic dilatation. So mainstay of managing corrosive esophageal strictures is endoscopic dilatation, but you have to never dilate in an acute phase. Like patient, like in acute phase, the tissue is extremely friable and very necrotic and easily perforates into the mediastinum. So never dilate in an acute phase. Wait for 3 weeks. And dilatation is something you have to do it in, it doesn't go away in one session. You have to keep doing it for multiple sessions. Most feared complication with dilatation is also your perforation risk. So there are two techniques, balloon and bougie. You would prefer a balloon so that bougie can cause an iatrogenic perforation. So coming to surgery, indications are all your complications where you suspect perforation, mediastinitis, sepsis, peritonitis, shock, and there is evidence of grade 3 necrosis in CT scan. These procedures include esophagectomy and gastrectomy. So this is a proposed algorithm for management of acute injury by Indian Critical Care Medicine Journal 2019. So if a person with corrosive ingestion comes with suggestive features of mediastinitis and peritonitis, you can right away try to take up for emergency laparotomy. If there are no signs of mediastinitis and peritonitis, if the availability of CT scan and is available, go for a CT scan, grade the CT scan according to type 1, 2, and 3. If it is type 1, there is no indication of endoscopy. Type 2, you can wait for the endoscopy. Type 3 is an emergency surgery. If there is no CT scan available or an expertise, like you can go away with corrosive injury scaling by endoscopic assessment of Zargar's grading. So one of the rarely seen like presentation to ER is ocular burns of post-corrosive poisoning. So it can cause corneal destruction and limbal stem cell damage and permanent blindness. Always time is vision. So do not wait for the history. You can right away start irrigation of the eye. You can start with crystalloids, NS and RL, and always evert the eyelids to remove any particles which are stick to your eyelids. And unlike oral injection, steroids can be beneficial in ocular burns. So complications, as we discussed already, early would be perforation, bleeding, and shock. Late would be most commonly esophageal stricture, recurrent strictures, and gastric outlet obstruction. And there is risk of squamous cell carcinoma in a corrosive poisoning patient, but the latency period will be from 15 to 30 years of after the injury. So these patients have at least 1,000 to 3,000% the risk of developing a squamous cell carcinoma. So to grade the or to predict the severity of the stricture or grade the stricture, we have a scoring system called RULE. It's an acronym which has a components of drooling of saliva, reluctance to eat, or having dysphagia or food intolerance, or when there is presence of oral or oropharyngeal burns, and number of other clinical features like persistent fever, hematemesis, abdominal tenderness, retrosternal pain, dyspnea, and high WBC count. So according to the scoring system given in this table, it can be scored. A score of less than 4, less than or equal to 4 will predict higher risk of stricture formation. This scoring system is mostly used for pediatric patients. Coming to disposition, so discharge only after observation for 6 to 12 hours. Only if there is asymptomatic mild cases when you clinically feel it's a low risk ingestion, when the patient has no symptoms or if he's trying to tolerate orally. Admit any moderately or severely acute ingestion cases, like if the patient is symptomatic, if there is grade 2 level injuries. In ICU, mostly grade 3 shock patient, perforations and peritonitis patients with intubations and all the complications post the corrosive poisoning have to be monitored. And coming to long-term follow-up, like for all the moderate to severe, you always have to come for a stricture surveillance repeatedly to the medical gastro, and if required, you can go for a dilatation. So how do we prevent this corrosive ingestion? The incidence of this poisoning has come down in developed countries due to very strict laws. We still have to have stronger regulations in developing countries, and we have to avoid sale in unlabeled containers, and somehow restrict the easy access to all the corrosive agents. Use childproof containers and while packaging as well, and parental awareness, like keep chemicals out of children's reach. Coming to special pointers, so these will be some scenarios. How do we approach it? How if a patient comes with an unknown or a mixed component, just orally he says that I have consumed some floor cleaner or a toilet cleaner, how do we approach it? So this is a very unpredictable pattern. So you always, when there is an unknown or a mixed component, please treat it as a severe form of ingestion. So all your ABCD approach always considered as severe form until and unless it is proven otherwise. They try to find out what type of liquid it is later. So next is your alcohol-based ingestion. So usually patients with suicidal intent can binge alcohol and then still have a thought of having corrosive ingestion. So in on already alcohol ingested patient, there are the protective reflexes which are in our body are already reduced. So there is high chance that the patient can consume large volume of the corrosives. So always consider a severe injury in alcohol based ingestion as well. So uh, coming to large volume, uh, um, large volume when a person ingests large volume ingestion, it often surpasses the esophagus, stomach, and goes through ileum and jejunum. So high likely it causes small bowel injury, and airway injury is not equal to GI severity. So and normal mouth is not equal to normal esophagus. So what happens is when there are two forms of corrosives, let's say liquid form and solid form. Liquid form pass quickly and they can pass the oral cavity and reach the esophagus and stomach. Oral forms like detergents or something which will stuck in your oral cavity, causing excoriations or whitish membranes or ulcerations over your mouth and oral cavity. So based on that, we have to clinically decide. And deterioration can be delayed. So patient looks very stable initially, but eventually when you evaluate, the patient dramatically can deteriorate because we are not aware of what's happening inside. So as I already discussed, early feeding for mild cases who are able to tolerate actually prevents stricture formation. And we discussed about the long-term risk of the cancer. And what is the role of H2 blockers and sucralfate? So H2 blockers like ranitidine, famotidine have no role. Studies say that they have no role over the this corrosive poisoning, whereas sucralfate showed some beneficial role. So H2 blockers are always inferior to PPIs in corrosive poisoning, whereas to after PPI, sucralfate can act as a barrier, so you can add as a secondary line treatment. Coming to a pregnancy where rarely you see a pregnant woman ingesting corrosives and coming, always you stabilize the mother, the fetal also have the better outcome. So always treat the mom aggressively so the fetal outcome is better. And all the patients should be counseled by a psychiatrist before discharge. It actually helps to repeat the further future attempts and actually address the underlying cause. So these are my references. These are from Emergency Medicine, Tintidali and Rosen's latest volumes, and World Society of Emergency Surgery Guidelines for Esophageal Emergencies 2021, and Indian Journal of Critical Care Medicine 2019 volume. So what to conclude my topic, like corrosive injury can start within seconds, but your decisions should be very on point. Always airway first, and unlike other poisonings, here do not doing something doing nothing is better than something. So do not put blind NG tubes, or do not do an iatrogenic perforations, or and there should be multiple follow-ups with the medical gastros. Thank you. If anyone have any doubts, please feel free to ask any doubts. Satish sir, you want to add something?
That's it. That's a great topic. Very nice presentation, Divya, Dr. Divya. I would like to thank Dr. Divya and Yashoda Hospitals for providing me with this opportunity. Okay.
Yeah.
Thank you all.
Thank you.